Sorry, Megan, can you hear us?
Yep. Hold on.
Hi, my name is Jane Henderson, and I am the harm reduction consultant with the Opioid Dependence Treatment Center of Excellence, housed here in Eastern Health. Although I am housed in Eastern Health, my role is across the 4 RHAs. And with me today is...
Hi, I'm Alex Morgan. I am the Harm Reduction Education Coordinator with the AIDS Committee of Newfoundland and Labrador here in the Eastern region. And I also work really closely with our SWAP program, which is also better known as the Needle Exchange Program.
Okay, so today we have about a 45-minute presentation on the basics of harm reduction. So basically, it's just the practices and principles of harm reduction. So we're just going to work the first slide. So the learning objectives today is really, we're hoping that we will give people a practical knowledge of harm reduction and how it relates to substance use disorder. In my role, I'm more narrowly focused on opioids, but a lot of the things that you're going to learn today can actually be put across many different substances. So during this webinar, you will understand the basic concepts and principles and the application of harm reduction. You'll also begin to be able to recognize when practices in your day-to-day work may be contrary to those principles of harm reduction. We're going to talk about how to reduce stigma and discrimination against people who use substances. And a large part of this is actually becoming an advocate for yourself for the integration of harm reduction practices in your own work. So here is a snapshot of what 10,000 Canadians look like. I put that picture here because I wanted to give everyone a really great visual of how many people have actually died of an opioid overdose in Canada since 2015. So that's 10,000 people, which amounts to about 11 Canadians every day. We actually put this up, we came up with this, this statistic in May of 2019, and less than a year later, we know that that number now has risen to over 14,000 people. So we're certainly in a public health crisis around opioid overdose. And like I said earlier, we are focused here a little bit more on opioids, but what we are finding is that many times when people are overdosing, it's from polysubstance use. So again, many of the practices and principles can be applied across the board. So how that relates locally in Newfoundland, in 2016, we had 18 deaths and 57 hospitalizations. In 2017, we had 33 deaths and 84 hospitalizations. And in 2018, we had 10 deaths and 57 hospitalizations. The numbers for 2019 are still being compiled, but we do know that there is an increase, certainly in the first quarter of 2019. We're just waiting for those numbers from NILCHI to come out, but we are seeing certainly an increase in deaths. So what is substance use and dependency? And there's a whole pile of different definitions of that. We just simply say it refers to the use of drugs or alcohol and includes substances such as cigarettes, illegal drugs, inhalants, and solvents. We say that dependency occurs when a person needs frequent repeated doses of that substance to make them feel normal. And we certainly believe that addiction is a disease of the brain and that it is characterized by compulsive drug use despite those harmful consequences. And I think that's really hard for a lot of us who work in mental health and addictions because we see so many of our clients suffering. We see all these harmful consequences. And in a way, you know, it's hard for us to understand why someone continues to use substances, even though they're getting those harmful consequences. So it takes a deeper understanding of the complexities of substance use to kind of figure that out. So there is a spectrum of substance use. And this is just a simple graph of that we got from the Canadian Mental Health Association. So there is actually a lot of substances that are used for a beneficial purpose. And we believe, it's believed that they have positive health and social effects. So we can talk about coffee or tea to help you in the morning, start your day, moderate consumption of, say, red wine, or even the sacramental use of ayahuasca or peyote. Then we have recreational use. So that's when you have small amounts or really negligible health effects. We call that casual, non-problematic, because you're not really seeing a whole lot of problems with the substance use. And then we see problematic use, and that's when you start to see more negative side effects. You can see negative side effects for society, for individuals, for families. You can see people getting DUIs, people binge drinking, people using harmful routes of administration if they're using injection drugs. And then we see chronic dependence, and that's when uses become habitual and compulsive. And again, it's despite those negative health and social effects. For the most part, we spend a lot of our time focused on the chronic dependence piece. And that actually, depending on what you read, the general consensus is that that only amounts to about 5% of all substance users. So we do spend a lot of time there because that's where we are seeing those really harmful side effects. But again, that's only 5%. So all the other people who are using substances fall somewhere else on the spectrum. The most important thing for us to understand is that we need harm reduction measures throughout every single one of these spectrums, right? So I always use myself as an example. I say I have casual problematic use of substances. So I enjoy, sometimes I drink on the weekends, or I'll have a beer, or I'll have some wine. And there was a time when I kind of started to see even my own personal substance use become somewhat problematic, in that as I started to get older, I started to get hangovers, and it kind of started to affect my life, right? I had children, and I found it like I wasn't such a great parent the next day because I was kind of like hungover. So I really had to figure out some harm reduction measures along the way. So for me, of course, I always made sure that I had a safe ride home, so you never drink and drive. But I started to drink less and to pace myself and to drink water throughout the night. And that would actually help lessen the effects of drinking for me. And again, so that again, the message is that we need harm reduction measures all across the spectrum, and people can evolve back and forth on the spectrum, right? So it's not always stagnant. Okay.
Okay, so, and just before we go on to this next slide, I think it's really important what Jane said about, harm reduction. And I think when people hear the word harm reduction, they oftentimes associate it with problematic substance use. But it doesn't always have to be that complex. Like, we use harm reduction measures in our everyday life. When you wake up, you brush your teeth, that's harm reduction. When you get in your car and you drive to work, or you drive to your friend's house, you wear your seatbelt. That's a harm reduction measure. So anything put in place to reduce the risk of a high risk or just a risky behavior. So again, like Jane said too, we're focused a little bit on opioids here, but this whole harm reduction presentation can be associated to any form of substance. On this slide, we just have a list of some opioids. So we know that opioids are a class of drugs taken for pain relief or euphoria. They can be prescribed or they can be used illicitly. They're central nervous system depressants, so they can be taken to reduce pain and end-of-life care. We know that opioids are really great for that, morphine and end-of-life care, to keep people comfortable. They can cause relaxation, they can provide a high. And then here's just a short list of some opioids. So we have fentanyl, oxycodone, oxyneo, hydrocodone, morphine, heroin, methadone, and Percocet. We don't have cocaine on this list because obviously cocaine is not an opioid, but I always like to include and just remind people that, especially right now, we have a lot of drugs on the streets that are not classified as opioids, but a lot of the times they can be laced with a form of opioid. So I do like to include that because cocaine is one that we see a lot that's oftentimes getting laced with an opioid.
So now we're just going to talk about what is harm reduction, and it kind of is I don't want to say it's a buzzword, but it's something that we're hearing a lot about and it's starting kind of to get a lot of attention. So harm reduction is simply a philosophy that includes a range of support services and strategies to enhance knowledge, skills, and resources with the aim of keeping people safe and minimizing death, disease, and injury from high-risk behaviors. That's kind of the academic definition. So harm reduction acknowledges that high-risk behaviors occur, and again, they often are ambivalent to change. And it also recognizes that individuals are experts in their own lives. And this is kind of a theme that you're going to see throughout the presentation, and that harm reduction really does honor the person who is actually going through this, the person who actually is using substances. And this, of course, we're going to touch on this again later. Harm reduction is a public health response focused on increasing safety and minimizing injury, disease, and death related to high-risk behaviors. It's kind of taken that shift away from kind of the justice model that we've been so heavily focused on for such a long time, and it's focused more as it kind of believes that we need to start looking at substance use through a public health model versus a justice one. And it also recognizes that abstinence is not always realistic or desired. And we must meet people where they are. And we will talk more about it later, but it is true. Abstinence is not always something that everyone can do, right? And for the longest time, we have been focused on, the just saying no, zero tolerance policies, and all this sort of stuff we know that have been an epic failure. So harm reduction involves a bunch of strategies that we're going to talk about. It can be integrated in programs, policies, and practices. And again, the whole aim is just to make people healthier, right? It's part of the 4 pillars that we have been used traditionally to address substance use. So it goes along with prevention, treatment, and enforcement. So for my past career, I worked at a community organization called Choices for Youth. And we were practicing harm reduction for a real long time. We didn't always call it harm reduction, but we did certainly work through that model. So a while ago, we were kind of, a few years ago, we wanted to craft up kind of a definition of what that actually meant. And I like to include it because I think it's really a really succinct definition. It says, in the absence of perfect choices, we help people choose the one that causes the least harm. We do this so that we have the opportunity to work with these people again tomorrow. I think the beautiful part of this is it says in the absence of perfect choices, right? Because I think for a lot of people, there are no perfect choices. And many of the people that we have worked with for a long time haven't had a whole lot of great choices in front of them. And for a long time, I know personally, I didn't understand that because I thought the choices I had in front of me were the same choices that the person next to me would have in front of them. So it's no longer okay that we think that everyone has, that everyone has the same choices in front of them. We're going to get more to that in a little while.
Okay, so I'm going to give a quick just overview of some of the harm reduction things that we have in place here in the province. Depending on where you're listening to this from, a lot of these do come from the Eastern region. We've tried to expand provincially as much as we can, but some of these are specific to the Eastern region, or St. John's, I guess, more specifically. So the first one we have there is the Opioid Dependence Treatment Center of Excellence, which is where Jane comes from, and that one's on a provincial level. I don't know, Jane, if you want to maybe say a word, but she's better at describing it than I am.
Yeah, so here at the Center of Excellence, our role is just to kind of ensure the proper delivery of opioid dependency treatment services. And we work within the 4 RHAs. So we work here in St. John's, which of course is Eastern Health. We work in Central Health, in Western Health, and in Labrador Grenville. So again, it is provincial in scope. And a lot of the work we do is actually in response to Towards Recovery, which is the all-party committee document on mental health and addictions. And the ODT, a lot of our work is in response to that.
Perfect. So the second one there is the Opioid Treatment Center. So they provide Suboxone and Methadone to anyone who is in need, create access to harm reduction treatment that allows people to control their cravings. And this is really helpful so that people can focus on other things in their lives as opposed to their addiction. The naloxone kit distribution program, so that's the take-home naloxone kit program. that's provincial as well. So I think we have 100 and
yeah, so we have about 150 kid contacts.
Yeah.
So we have about 111 distribution sites across the
province. Yeah. So we oftentimes do pop-ups for training as well. So I know in the Eastern region, we try to get out to big events like George Street Fest, the Regatta, things like that. So we can kind of create awareness in the region as well. And then like Jane said, we have our satellites who distribute naloxone kits as well. We have our needle exchange program, which like I said earlier, I work really closely with the AIDS committee. So SWAP also has satellite sites. They have a site here in Eastern, and we also have one in the Western region as well in Corner Brook. And in Eastern, we have satellite sites through Choices for Youth, Thrive. We have some shelters in the region as well who give out safer using supplies to their service users or residents. And we also operate from a mail out program as well. So if you're anywhere outside or in between of St. John's or Corner Brook and you require safer using supplies, we'll actually mail that out to you. And then we have our mobile van that runs on Tuesdays and Thursday evenings. So individuals can just call in and place an order, and the volunteers on the van will go out that evening and meet you where you are physically in the community. So you just need to give an address and a phone number so we can reach you later that evening. And all of those services are anonymous. We also have the City of St. John's installation of the sharp boxes. So this is kind of new, and we are looking at expanding this provincially. We do have other regions who are looking at accessing the sharp boxes. It's just a matter of getting more of them manufactured. But we do have, I think, 12 of them around the city right now. So they're basically just big sharps containers that we've placed. Some look like mailboxes, others are a little bit bigger. And we have those around the city. So if you go on the City of St. John's website, you can actually see a map and a list of locations of where those are if anyone you know or you yourself needed to access those sharps containers. So we're going to quickly go through each one of these, but we're going to talk a little bit about the principles of harm reduction. So we have pragmatism, focus on harms, emphasis on human rights, involvement with people with lived experience or people who use drugs, maximizing of options, and priority of immediate goals. So like I said, we're going to quickly break down these and we're going to go through each one of them.
So the first one is focus on harms. So harm reduction really attempts to just focus on the harms of the drug use and not the drug use itself, right? So the fact or extent of an individual's drug use is secondary to the harms, right? So I think, you know, in situations where, say, a substance user would go to a healthcare professional and say, hey, you know what, like I have a problem, you know, I have an abscess, for example, from injecting drugs. Many times the conversation would quickly turn to, well, we need to talk about your drug use. We need to talk about you becoming sober from that drug use, right? Whereas harm reduction focuses on those harms that drug use has caused. So the priority is always to decrease the negative consequences of the drug use, or of the substance use. And while harm reduction emphasizes a change to safer practices and patterns, it recognizes the need for strategies all along the stages of the continuum, right? So it is a shift from the way that we, you know, traditionally, I think, worked with a lot of people who use substances. So instead of saying, you need to stop using those drugs, we can now say, okay, well, you know what, this person is using these drugs. So here's a safer way to do that. We're going to focus on the harms that drug use is causing, not the drug use itself. So pragmatism, it's my favorite one. So harm reduction accepts that the non-medical use of psychoactive or mood-altering substances is a universal phenomenon, right? So it recognizes that people are going to use substances, right? We've tried to stop it. We've had prohibition. We've had, you know, crazy archaic laws. We've tried everything that we could, but people are going to use substances, right? It recognizes that substance use is complex and chronic dependence can bring with it varying degrees of social harms. And yeah, so it's very pragmatic in its response. So it just says, you know what, people are going to use substances, so we need to figure out how to keep them safe, right? It's going to save us money. It's going to help. It's going to help them. It's going to help society as a whole.
So human rights. So we know that harm reduction accepts the individual's decision to use drugs, and no judgment is made either to condemn or support the use of drugs. And it supports informed decision making in the context of active drug use, and the emphasis is placed on personal choice, responsibility, and management. So harm reduction is really grounded in ethics and the person's right to autonomy. And a good example that we always like to use for this one is it's similar to how we would give insulin to a type 2 diabetic, regardless of if they choose to live a healthier lifestyle or not. So this doesn't mean that we don't offer them education or resources. It doesn't mean that we don't support the person. We're just committing to working with the person where they are, and again, recognizing that continuum. So involvement of people who use drugs or people with lived experience is the other acronym we use for that one. So people who use drugs are the best source for information about their own drug use, and they need to be empowered to join the service providers to determine the best interventions to reduce harms from drug use. Harm reduction recognizes the competency of people who use drugs to make choices and change their lives, and the active participation of people who use drugs is at the heart of harm reduction. And it's important to recognize that, like, there has been historically a lack of people who use drugs or people with lived experience viewed as partners in their own recovery. So I know for myself and Jane, a lot of the working groups that we work on, or whenever we're doing any sort of project or research or anything like that, we're always trying to involve people with lived experience. And I think that goes for most of the working groups we work on, if not all of them. But we do recognize the importance of having that voice of lived experience in the room, because we are not the experts in that, but they are.
So maximizing options. A lot of people in social work probably was very familiar with this idea. So we know that people benefit from a variety of different approaches. And the more approaches that we can give to people, the better. And we know that those approaches need to be prompt. We need to have rapid access to a bunch of different things. Individuals and communities affected by drug use also need to be involved in the creation of the effective harm reduction strategies. So again, the more options we can give people, the better, the more chance they are to be successful in their goals.
Priority of immediate goals. So I think this one is really important. So harm reduction starts with where the person is. And again, that common theme of meeting the person where they are in their drug use, with the immediate focus on the most pressing needs. Harm reduction establishes a hierarchy of achievable interventions that can lead to success, and then incremental gains that can be built on over time. So again, this just goes back to meeting the person where they are. A good example is if somebody presented in the emergency room and they had a huge abscess on their arm from using substances. So you're not going to go right at that person and say, hey, let's talk about your addiction. Let's talk about your drug use. The most pressing need at that time is the abscess on the arm. So let's say, hey, you know, let's take a look at your arm. Let's clean it up. Let's see what we can do. And then relationship build to the point where you maybe be able to talk to that person about their substance use. Recognizing that recovery is not a straight line. Again, the continuum, there are many ups and downs. And recognizing that relapse is a part of recovery. So, you know, in the work that I used to do, I used to work in the emergency shelter. If an individual came in, you know, sometimes they're coming from living on the street for a few days, totally depends what their situation is. And we were required to do an intake. Sometimes that's not going to happen right away. So it's important to say, you know, do you need something to eat? Can we get you comfortable in a room? Do you need a shower? Because that's the most pressing need at that time, as opposed to completing the intake.
Okay, so practicing harm reduction, we have to make sure that we practice non-judgmental care. We have to provide cultural safety. We have to empower clients. We constantly have to be self-reflecting upon our own practices. We should be using strength-based approach and trauma-informed care. We always must consider the root causes of substance use And at the crux of all this is building those trusting relationships. So we're just going to quickly go through a couple of these. So the first one is, sorry, we just missed it. The first one is non-judgmental care. So non-judgmental care is providing those non-coercive provision of services and resources. So again, it's giving someone, first of all, a place to be able to talk about their substance use, a place to be honest, a safe place for them to be sick. And it's about not coercing them into a certain line of treatment, right? So it goes back to valuing what that person really wants and having them actually partake in any sort of plans going forward. And we have to make sure that we provide that non-judgmental care. And I think this is a huge challenge. And I think that, I think historically we have had a lot of judgment against people who use substances. I think similar to what we've seen in mental health. I think we've made some great strides in mental health about the judgmental piece, but I still think that we do have quite a lot of judgment happening, and it's something that we need to remain vigilant on.
So practicing harm reduction with empowerment. So people who use drugs are the primary agent of reducing the harms of their own drug use. So again, people are the experts in their own lives. Harm reduction seeks to empower people who use drugs to share information and support each other in strategies which meet their actual conditions of use. So we know that any great plan requires considerable collaboration with the client, and we oftentimes need to start to move away from those paternalistic ways that sometimes I think a lot of us do hold in our own practice, and recognize that we do not know best, but the individuals who are accessing our services know best about themselves. I have a really good example of a conference I went to back in September, and they had a people with lived or living experience panel. And one of the ladies told a story about how she was a nurse for years, and she really struggled with opioids. And when she was going to seek out services, so whether it be counseling or seeing a doctor or seeing a nurse practitioner, whatever it may be, that they really approached her in a way where they were simplifying everything they were talking about, and they were, she felt like she was treated very differently and treated as if she had no experience in her life. And, she made sure to say that, they really didn't take into consideration that I myself may have a really rich, diverse background, and she did as a nurse. And she said, it's not to say that sometimes we do need to simplify our language and we do need to break things down for people, but it's important to take into consideration that the people that we do work with oftentimes do have a very rich, diverse background themselves, and they are educated as well, and they are the experts in their own lives. So it's important to take that stuff into consideration when we are working with our service users or clients.
So self-reflection is something that I think is super important in certainly in harm reduction, but in mental health and addictions for sure. And I think that it's something that we constantly need to be doing, and kind of always reflecting about how we respond certain ways to certain people. So self-reflection is understanding how our personal values and beliefs are reflected in practice. And I worked frontline for many years, and sometimes I've kind of just kind of at the end of the day, you go home, you think about certain situations, you wonder, how could I have handled that better? And it's all about kind of building up your skills and improving. I know one time I was kind of new at a job, and we were on this walk, and I witnessed a young pregnant woman, and she was smoking. And I remember I kind of, as a parent myself, with a young baby at home, I remember thinking, oh my God, how can she smoke, and how dare she, and she's not considering her baby, and this is wrong, and and I kind of had all kinds of judgments flowing, and I just was very self-righteous and all that sort of stuff. And one of my coworkers took me aside and said, well, you know what, this young woman a year ago was in hospital with endocarditis and a pretty serious heart infection from some heavy drug use, and right now she's just smoking, so you need to calm down, right? But to me, I didn't know her story, and I didn't know, and her story is really none of my business, you know what I mean? But I was very judgmental, right? So that kind of really was a turning point for me in my career and how I interact with people and how, and again, it's going back to understanding that the choices that I have in front of me are very different than the choices someone else has in front of them. Many of the people I have worked with over the years have been very vulnerable populations, and they have lived in poverty. They've been treated very unfairly. So I have to understand that their decisions were poor, and worse, right? And then we kind of get mad when they choose one of those poor decisions in front of them, when really they're choosing the one that works best for them, right? So when they come to us, we have to make sure that we don't judge them for that, right? And that takes a lot of self-reflection. It's something we constantly have to do throughout this. So cultural safety, we talk a lot about cultural safety, and we're not just talking about our Aboriginal folks. Of course, we absolutely must recognize, especially with our Aboriginal folks, the social and historical context of health and healthcare care inequities. But we must, as a broader piece, we must understand that many people in marginalized groups experience worse health and access to services. Again, I worked at a place called Choices for Youth, and I worked with some vulnerable young people, and I know that when they used to present at, say, an emergency room, if they went alone, say without a supportive person with them or an advocate, they would get worse services than if they went with a staff, for example, right? So we must make sure that wherever someone is, that we must always understand that marginalized groups are experiencing worse health and access to services, and that's something we must do better at. So a strength-based approach, again, is something a lot of social workers, teachers, healthcare providers have been working on for a long time. So strength-based approach simply says that, you know, we believe that everyone has the potential to determine their evolving story, as well as define who they are, right? So it's a belief that not I believe when I see, it's rather I believe in you and then I will see, right? So we always focus on strengths, not labels. I used to be a counselor. One thing I made sure I always did is if I saw a client after the weekend, I would always ask them, hey, how was your weekend? Like, did you see a movie? Did you go to a hockey game or whatever? I made sure I didn't ask them right away. Did you stay sober, or, you know, did your safety plan work, for example, right? So I always wanted them to know that I saw them as much more than their addiction, right? So a person's perspective of reality, again, is their primary story. And it builds on the client's abilities and emphasizes the saying, the person is not the problem is the problem. And that is such a great thing that I would like for everyone to take away. And that the problem is the problem and it's not the person, right? And when I used to teach, we used to say, there's a lot of good kids who do bad things, right? And this is very similar to that. We know that a lot of people are struggling with different things, and the problems are the problems, not that person itself, and they are not their addiction. And another real integral part of practicing harm reduction is kind of how it interweaves with trauma, right? So clinical studies have found that over 80% of clients with substance use issues had experienced abuse. In my personal practice, in my years working frontline, I would say an even higher number. I'd go up to even 95% of clients that I've worked with who've had, you know, kind of chronic substance use have also experienced trauma. The two go hand in hand, right? Approximately 75% of homeless population use drugs or alcohol as a means to self-medicate to deal with the traumatic experiences and abuse they face. And, you know, like we're all on social media, we're on Facebook, we're on kind of all these different social platforms. And I kind of see a reoccurring theme many times about, I don't want to say an anger towards homeless people or people who are living in poverty, but I feel that you know, a lot of times we won't give a homeless person, say, $1 or $2 or $5 or whatever, because they're just going to spend it on alcohol, right? And really, to be really clear, I consider myself a pretty strong person, but if I lost my home and my family and my job and I was struggling with substance use, I would absolutely use money to kind of self-medicate myself, right? And we have to understand that a lot of people are self-medicating just to deal with the traumatic experiences they face that were absolutely not their fault, right? We know that male and female sexual abuse survivors experience a higher rate of alcohol and drug substance use. And again, in my personal experience, I was doing some research not too long ago, and I went through a pile of files, and vast majority of women who have had some chronic substance use disorders have had some pretty significant childhood trauma, a lot of times sexual abuse, and about, depending again on what you read, about 60 to 70% of males as well, right? So we always have to keep that in mind. So trauma awareness, so we have to be aware of the prevalence of traumatic experiences with people who use substances, right? How that impacts in the development in the brain and the relationship to physical health, mental health, and substance use. And now with our new brain scan technologies and kind of all the cool things we can do, we can actually see how traumatic brains actually look different than a non-traumatized brain, right? And we have to accept that people make the choices they do in an effort to manage their trauma. And I will say this until I'm blue in the face, I've never met a substance user, a chronic substance user, who was like, you know what, this is a fantastic life and I'm really happy, right? Everyone I've worked with have had it really hard, right? And a lot of times they are using those substances to manage that trauma that they have been facing, right? So trauma-informed practices and harm reduction support each other in providing safety, control, and connection to people. I think another important piece of all this is that we don't need to know someone's trauma to actually work with them, and it can be quite dangerous for us to ask people about their trauma. You can actually re-traumatize them. My rule of thumb now is I treat everyone I meet through a trauma-informed approach. I just assume everyone has had trauma, and that's kind of my rule of thumb for sure.
Okay, so I'm just gonna go quickly down through the list of some myths and realities about harm reduction, and I'm sure a lot of these will look really familiar to most of you. You've probably heard them time and time again. So with harm reduction, the first myth is that it increases crime and public disorder, when the reality is that it can actually lead to a decrease in public disorder. We get this one a lot, especially working out of the swap office. People always ask us like, oh, like, does anyone try to like steal your stuff? Does anyone try to like poke you with a needle? Do you see the police presence a lot? And absolutely no. I always tell people I've worked in that building for 3.5 years now, or close to 3.5 years, and I've never seen a police officer anywhere near the swap office before. So that's definitely one of the biggest myths about harm reduction. The second one there is that harm reduction measures cause anti-abstinence, when we know that the reality is that it's simply on the continuum. And we recognize that abstinence is the most effective way of reducing harms, but it really just lies at one end of the continuum. And we know through supported evidence that when we listen and when we collaborate with our clients and our service users where they are, we always have better outcomes. And anti-abstinence is not always the desired outcome, like Jean said earlier. It's not always the desired or realistic outcome. Another myth there is that it enables and promotes drug use, when the reality is that we have no evidence of this. So harm reduction just respects where the person is on their journey. There's no compelling evidence that it enables or promotes drug use. We know that harm reduction strategies provide greater links to community care, referrals, and it provides an opportunity to build relationships with our clients. The next one there is that harm reduction is ineffective, when the reality is that it has saved countless lives and it has allowed people to live healthier. So a good example of this is the naloxone program. So the naloxone program is, like we said earlier, provincial wide, and it's probably one of the biggest harm reduction strategies that we have out there right now, and it has saved countless lives. I don't have the number off the top of my head, But we do have good numbers of the naloxone program saving people or reversing an opioid overdose. So that's one good example of how harm reduction is really effective. And yeah, and the SWAT program is another one too. And that kind of goes hand in hand with this last point, so that it drains resources from treatment services when the reality is that harm reduction activities are cost effective and they prevent costly health outcomes. So when we look at places like the needle exchange program that are trying to reduce the risk of transmission of hepatitis C or HIV or sexually transmitted bloodborne infections, that's really cost effective for us, because the cost of one hepatitis C treatment for one individual is upwards of $60,000. So you think about taking hepatitis C away from one person, how much money that is saving us as a province. It's a lot. So how stigma relates to harm reduction. So we know that stigma is the negative attitudes and beliefs about a group of people due to their circumstances in life. It includes prejudice, judging, labeling, isolation, and stereotyping. Stigma causes isolation, feelings of shame, guilt, and worthlessness, and it increases high-risk behavior and the risk of death. And then self-stigma there on the bottom is when somebody internalizes social and structural stigma. So an individual will take those negative messages that people see or how they feel about themselves, about people who use drugs, and they will directly take that and then apply it to themselves. So we know that this can lead to negative feelings about themselves and a loss of hope of recovery. And I know for both Jane and I in our work, I think stigma is definitely one of the biggest pieces that we've heard or have seen that people say that makes them continue to use. So they feel judged, they have no one to reach out to, they have a lack of supports, people are labeling them, they're starting to isolate because they have no supports, and then they just continue to use because it's just that continuum.
So structural stigma is a form of stigma that happens in institutions. So a little while ago, a couple of people, there's was some white papers published by some leaders in Eastern Health, and they actually consulted with Eastern Health employees. And what they found is that there was a pretty good understanding of addiction, and that, you know, it was a brain disease, it was chronic, and all that sort of stuff. So people kind of fundamentally got, you know, substance use, right? But a deeper dive into that showed that there was still a perception that addiction was based on choice, right? And that's a problem, because that takes away it takes away kind of the power, right, that people have. So when we criticize people or blame them for the choices they make, without understanding the larger picture, it can be very harmful to people, right? And studies have shown that the personal values of people who, social workers and nurses and doctors and drug workers, can impact client outcomes. So if a client comes to me and they know that I'm judging them on the choices that they are making, and that I believe that they're actually making that active choice to continue to use, that can be very harmful. Structural stigma occurs when people who offer services can stigmatize patients. And again, that's not taking requests seriously. And, you know, as someone who has worked frontline, I've actually seen this happen. You know, we've heard things like, you know, I have a waiting room full of, you know, sick people here, and this kind of drug user wants to come in and get seen, when I have, you know, legitimate patients in the waiting room, right? That is something that we've actually heard not too long ago, right? So, you know, not taking requests seriously, right? Not connecting with people, not referring them to services. You know, and we have to keep in mind that we have you know, we have this fiduciary responsibility, but we have a duty of care to work with everyone, and we have to ensure that we give people a safe place to be sick. And if someone can't be sick in a hospital or with their doctor or with the nurse or with a health professional, then where can they be sick, right? So we need to make sure that we're challenging structural stigma all the way.
Okay, so why is harm reduction so hard to accept and what can we do? So we need to be aware of personal assumptions, values, and biases. So that idea or that question in the back of your head that says, I would never do that, we need to really be aware of that and those judgments that we make on people. What are my professional obligations? So your duty of care is really important to remember. What knowledge and skills do I need to support this person? And if you don't have those knowledge and skills, or if you feel like you can't support that person because of maybe your own values and your biases, who can I connect them to, or who can I refer them to that can support that person? It's important to be aware of body language and voice. You don't want to re-traumatize a person. I know something that like we often think about is bringing somebody into an office and closing a door behind them. Some people aren't really comfortable with that. It's a really quick way to re-traumatize somebody. Think about if you're being person-centered in your own practice. And lastly, but most importantly, show kindness. We're all in these caring professions or whatever profession that you are in because you care. So it's really important that we're showing compassion and kindness for all of our clients.
And I think that's it. So right here we have, seems like it's just my contact information, but happy to have a conversation with anyone, happy to do this presentation live. Myself and Alex certainly can do something like that. So I have my phone number here, and my email, which is the best way to reach me. So jane.henderson@easternhealth.ca. Alex, maybe you can give your numbers, your contact.
Yeah, so I can be reached at 579-8656, and my email is amorgan@acnl.net. And we're located down on 47 Janeway Place down in Pleasantville, so right next to this building that Jane has listed here.
So again, if anyone wants to reach out to us, we might not always have the answers, but we'll certainly try to connect you with someone who does have the answers or find them out ourselves. So again, thanks everyone for listening, and hope you stay well.
Thanks everyone.